Thank you, Mrs. Chair Lady. Dear colleagues, it is an honor and a privilege to be invited to discuss CT in pediatric abdominal trauma. And when I undertook this task, I thought, okay, most of the people in the room will do CT for severe abdominal trauma, so my task is easy. But I would like to give you some new facts and some thoughts for consideration and discussion. The pathophysiology of abdominal trauma is straightforward. Following application of the force to the trach, you can see structural disruption and bleeding either at the site of the injury or remotely inside the abdomen. The sequence of events in organized environments involve the primary survey that has to be performed within the first golden hour, keeping the airway, breathing, circulation, and disability, addressing all these facts in order to prevent secondary damage. And we come into the picture during the secondary survey when the surgeons evaluate the abdomen for obvious external injuries, symptoms, and ask for laboratory tests. In the next 18 minutes, we will try to understand that the pathophysiology of pediatric trauma and the way to address pediatric trauma is different in children, become familiar with types of injuries that can be appropriately evaluated with CT, and discuss imaging CT protocols. It is very important to realize that children that can look normal and have normal systolic blood pressures may deteriorate rapidly due to active bleeding within 3 to 5 minutes. Therefore, your clinicians will be very anxious to know what is going on in their abdomens and to define the life-threatening injuries. The good news, as Dr. Mille said, is that children tend to stop bleeding spontaneously because of small vessels and strong vasoconstrictive mechanisms. And although most of the children that we will image will be treated non-operatively, we need to do some form of imaging. The algorithm of adult abdominal trauma is obsolete in children. Yes, we do perform FAST for unstable children, but we need to reduce the number of negative abdominal CT scans and the number of CT scans that only show minor injuries. The literature supported indications for CT in pediatric trauma are reasonable. They include external evidence of trauma as seen in from cases from the internet, and they include inability to evaluate children due to intubation, craniocerebral injuries, spinal cord injuries, gross hematuria, symptomatic children that are verbal and can express their pain, and external evidence or suspected abuse or a known history of bicycle handlebar injury. There has been an attempt during the last decade to come up with a clinical prediction rule to identify children at risk for intra-abdominal injuries, and these include 6 very common variables and simple variables: the low for age systolic blood pressure, the abdominal or thoracic pain because the abdomen starts from the nipples clinically, a femoral fracture, and 3 abdominal laboratory variables, altered liver enzymes, microscopic hematuria, and low initial hematocrit level. And these will detect 95% of children with potentially significant intra-abdominal injuries. Conversely, there's a large multicentric study, and I urge you to inform yourselves and the pediatric surgeons about it, about the children that are low risk for blunt abdominal trauma, with thousands of children being evaluated for the simple 7 variables. And this risk for intra-abdominal injuries has been stratified. And in order of importance, the presence of each variable, abdominal wall trauma, seatbelt sign, low Glasgow Coma scale, abdominal tenderness, thoracic wall trauma, symptoms as to increased risk for the presence of abdominal trauma by around 20%, whereas if all of these variables are lacking, you have a 90.9 negative predictive value for an intra-abdominal injury that needs treatment. And this would mean that the risk of fatal cancer development due to a CT scan of the abdomen far outweighs the risk of missing an important injury, and these children should not undergo a CT scan. And I urge you to visit this site because it has a lot of information about pediatric trauma and pediatric situations. This is your checklist. The common injuries are the liver, solid abdominal injuries, and as Dr. Miele said, with free fluid. But what we as radiologists need to rapidly exclude are vascular injuries, bowel injuries, hypovolemic shock as shock bowel manifestations, and pancreatic injuries due to the increased risk of complications. And then, during our secondary survey, look for the adrenals, the thoracic cage, and the bony structures. This unfortunate 5-year-old fell off the 4th floor and sustained a fatal brain injury, early reversal sign, C1, C2 injuries, cervical spine fractures seen in 3 planes. What do we do with the abdomen? There's mediastinal widening, a lump on the neck, bilateral humeral fractures. We rapidly clear the abdomen. In this case, there was only a symphysis pubis fracture, and we need to deal with the carotid space, vascular injury, and the craniocerebral injury. Therefore, in severely injured children following a high-impact injury, CT is better. This 4-year-old became unwell following bone marrow biopsy, and you can see contrast extravasating out of the vessels. MIP reconstructions show the site of a vascular injury in a large retroperitoneal hematoma, and you can appreciate the trajectory of the needle on bone widow algorithms. This 70-year-old fell off the roof, and he had a positive predictive rule for an abdominal scan. And you can see unexplained free fluid that on the late portal phase was filled with contrast that was extravasated from the gastroduodenal artery. Surgeon said it was an easy surgery because of the CT scan, and his life was saved. Vascular injuries, CT performs better. Conventional ultrasonography, fluid in the abdomen, some inhomogeneity in the splenic parenchyma. This is the CT scan of the same patient, small laceration upper part, a contrast blush at the middle part of the spleen, a larger area of devascularization of the spleen. When you need to grade the injury, ultrasound underestimates the degree of injuries. Is grading important? Grading has helped communication between the radiologists and the clinicians, and has helped surgeons to understand about non-operative management of pediatric patients. And what we are asked to do, to report, is the degree of coverage of the splenic contour by subcapsular hematomas, the depth of lacerations, the degree, the percentage of the spleen that is devascularized, and whether there's a large devascularization and potential splenic hilum injury. And in the recent year, there has been an attempt to incorporate vascular injuries into the splenic trauma grading system, to incorporate intraparenchymal, subcapsular, intraperitoneal active bleeding, and also contained bleeds as pseudoaneurysms and arteriovenous fistula formation. All the presence of these upgrade the severity of the injury. Similarly, for the liver, we need to measure the extent of liver lacerations, to measure intraparenchymal hematomas, to assess how many liver segments are devascularized, to assess how much covered the surface of the liver is by subcapsular hematomas, and to assess whether the lacerations involve major vessels like the porta hepatis or the ABC and hepatic veins. Periportal tracking doesn't necessarily mean that you have a liver injury. It is seen as hypodensity surrounding the porta hepatis and its branches. It can be associated with liver injuries, such as in this case with small lacerations, and then it is due to dissection of blood in the area. But it has also been seen following active fluid resuscitation thought to be lymphedema. But caution should arise among these surgeons because these children tend to be more severely injured. It should be remembered that no matter what kind of imaging you use, let it be ultrasonography or CT in the same patient, so extensive splenic injury, the decision for management will not depend on your imaging. It will depend on the failure of the child to respond to non-operative management with intravenous fluid and packed red blood cells. And it's very nice to belong to a trauma team like Dr. Karani showed this morning, where angioembolization is possible. Is grading important? Grading is important for short-term and long-term management because there are guidelines regarding close observation in the ICU, length of hospital stay, and how the surgeons guide the patients to restrict normal activities. And these have been validated since 2002. Is contrast blush important for us to find and interpret? Yes. Active extravasation morphologically would have ill-defined margins. You might see a spiculated pattern. You might be able to see a layered pattern at the vicinity of extravasation, as opposed to the pseudoaneurysms that are round or ovoid. But the way to discriminate those, you need a late phase. And if you routinely apply a late arterial and a portal venous phase, you will see that the active extravasation actually spreads either in the vicinity of the extravasation or remotely in other parts of the abdomen, whereas opposed to the pseudoaneurysms that just tend to fade away. And you must agree with me that this pseudoaneurysm would have been missed hadn't it been the arterial phase there. And clinically, contrast blush is important in children, not as much as in adults. In adults, it's practically an indication for consideration for operation. But in children, it has been associated with an increased transfusion requirements, and it sort of identifies the subset of children that might require high candidates for operation, especially if you have a liver contrast blush, and these children tend to be more severely injured. Bowel and mesenteric trauma, CT performs lousy regarding specificity and sensitivity. However, the signs that we should actively look for include pneumoperitoneum and a bowel wall defect, rarely seen in bowel transection, but unexplained free fluid, mesenteric hematoma, or stranding and bowel wall thickening. These cases are taken from the article from Dr. Straussy, are the findings that we need to evaluate and look for. And again, the most common imaging CT findings of bowel injury include unexplained free fluid, and we know that many children, asymptomatic, do have some amount of fluid, so this finding should be addressed based on the amount of fluid and the symptoms of the child. Free air, never forget the pitfalls. Does the patient have a pneumothorax? Has he been, is it a penetrating injury, or has he been previously operated? Bowel wall thickening can be very tricky, and the localized hematoma without or with vascular extravasation can be very obvious, but not one of the most common findings. Hyperperfusion complex is not bowel injury, is not an indication for operation, is an indication of active fluid resuscitation, and it manifests with diffuse bowel wall enhancement with or without luminal dilatation, fluid-filled enhancing bowel loops. Look at the major vessels. There's a small aorta, there's a slit-like IVC, the source of bleeding, a large extraperitoneal hematoma due to a pelvic fracture in the setting of abdominal trauma. We need to look for a source of injury and actively administer fluids. Key point: if you see diffuse bowel wall enhancement with or without luminal dilatation, look at the large vessels and consider shock bowel, where as opposed to bowel wall thickening that can be focal or diffuse and with free fluid, then suspect perforation. And of course, we need to perform CT appropriately in children, provided that it's justified. These are the basic principles: no multi-phase scans, collimated scans, and pediatric-specific imaging protocols. And in order to do that, and in order to plan your CT scan, you need to individualize and preferably look at the chest CT, see if there is any indication to include the chest in your imaging, the pelvis radiograph, look for fractures, and do the ultrasound yourself, preferably with IV contrast, so that you plan your CT scan beforehand. And make sure that if you're not a non-trauma center, you're not among those who do not tend to dose down their exposure parameters. And prevent your clinicians from asking a repeat CT scan. You can follow up with ultrasound unless you can really not conclude to what is going on. I think this is one of the most important slides of this lecture. If you are among those who do a non-enhanced CT scan before your contrast in children, just forget about it. Children don't have calcifications. This doesn't add anything to your diagnosis or grading for injuries. And you need to individualize and plan. If there's a pelvic fracture, you need to look for vascular injuries, and if you need to assess for any specific areas, collimate your delayed scan. And I will stick my neck now and say that in my department, we do a late arterial and portovenous phase of the whole abdomen when we have pelvic fractures and with displaced bony fragments, and we do an arterial and portovenous phase, arterial just the upper abdomen for not to miss the pseudoaneurysm, and the portovenous phase for the whole abdomen. And we are there to detect any vascular leaks for a possible delayed scan, collimated scan. And of course, I refer you to this very nice article. You need to reduce the exposure parameter size-wise and use all the vendor-available techniques to reduce your dose. One word for consideration: there's a lot of debate and nothing in the pediatric literature about it, about the split bolus techniques. If you have already done the ultrasound and you know that you have a renal abnormality, you can give 1/3 of your contrast and wait for 4 minutes so that it gets excreted from the pelvic ileal system, and then you can do a portal phase with the rest of your contrast, and make sure, in this nice case provided by Evelina Children's Hospital, that despite the fact that you have deep laceration and transection and the large perirenal hematoma, your pelvic ileal system is intact, as opposed to this case where you have extravasation of excreted contrast material that indicates a pelvic ileal system injury as well. But this needs to be validated in children. Conclusively, CT scan can perform better provided that is indicated in high probability of high-grade injuries, penetrating or multi-organ injuries, in suspected child abuse, when you consider all the ALARA principles and you have your checklist on top of your head. And with that, I would like to thank you for your attention.